Dr. Dressel and Mindy, actually, the NICU specialist, knew that time was of the essence, and so they jumped into their car, didn't wait for the ambulance, and so they were there actually as soon as Cade was born. They started doing the breathing treatments and got him intubated and IVs in, and so they actually had everything done that needed to do so he could be transported to the NICU before the ambulance even had arrived. So without them having the foresight to do that, he wouldn't be alive today. After I had my daughter, I wasn't actually even able to see her for 24 hours because I was so sick and bedridden. That same day, one of the nurses actually went into the NICU and took a video recording of her just laying there and kind of making, little baby sounds, and actually brought that into my room to let me watch it because I wasn't able to go see her, and that was incredible and definitely above and beyond what her call of duty was.
In Montana, we have about 12,000 deliveries a year. Of those 12,000 babies that are delivered, approximately 11% are born premature. And these are the babies that will go into the NICU. Here we take care of babies from the very tiniest of babies to the full-term babies who have problems.
The first time seeing Leah was really kind of scary. She was 3 pounds, 3 ounces. She had a respirator, she had IV, she had feeding tubes, she had the works, and she was in an incubator. It's not the way you expect to see your child. You have to, being a NICU mom, you get used to all the cords and monitors, and once you're there and learning that it's, the sounds aren't that bad, they're not that scary. You learn what they mean, and the nurses are really great helping you pick up your baby with all these cords and how to hold the baby, and it gets easier. It doesn't get so scary when you see all that stuff.
Because your baby is being admitted to an intensive care unit situation, please keep in mind that the first time you see your baby, it might be really scary. Your baby may be hooked up to many monitors, IVs, on a ventilator with a tube down the throat, a tube down into the stomach, and most people have never experienced this kind of situation before. It presents itself as a very impersonal situation. We're trying to mimic what you would be providing if your baby was still inside. We're never going to meet what mom can provide, but we can come really close. We will get you touching your baby as soon as we can. We'll get you holding your baby as soon as we can, but our first priority is to provide what your baby needs at the time.
He went from having the CPAP, the full headgear, where it's kind of like a little dinosaur snout, to the nasal cannula, which is just tubing, and he actually went home on that.
Your baby may end up with what we call a UVC, or an umbilical venous catheter, which is an IV that goes into the baby's belly button, and in this line they can get the nutrition they need, medications such as antibiotics. We will also as nurses be able to draw blood from the line, so we won't have to be poking the baby's heels. It does not cause them any pain going in. The main purpose of the UVC is to simulate nutrition to the baby that the baby received while mom was pregnant. If they are needing to continue on with IV antibiotics, then we will sometimes put in what we call a PICC line, which is a peripheral inserted central catheter. It'll go in one of the outer extremities. This is more of a long-term catheter. It's very small, it's very secure. They can receive antibiotics and IV fluids through that catheter as well.
Lab work can give us a lot of information that will help your baby, in that we can know how much oxygen are they getting. Is it enough? Do they need more? Do they need less? If they have ventilator support or some type of respiratory support, then maybe we need to help them breathe faster so that they get rid of a little extra carbon dioxide. And the blood work can tell us that. There's other things that we send to the lab as well. We can send not only blood, but we can send urine, we can send little cultures from the skin, things that help us know what's the matter with the baby and what is your baby's needs. What can we do to help your baby and support your baby while he or she grows up. When everything is said and done, our goal is for you to take home a baby that is healthy and you know how to care for your baby and that you can have a beautiful life together.
There are so many times the need for subspecialty care between 24 weeks and 27 weeks that it's important to put them in a medical center that has all the subspecialists. In our NICU here in Kalispell is that we have pediatric subspecialist in neurology, and we have a pediatric subspecialist in cardiology, which means we have two of the most important subspecialists for pediatrics and neonatology.
One of the things that parents should know is that most of the premature babies do well. A baby that's 28 weeks gestation, premature, they do very well. 99% survival, 99% survival without any problems.
Being discharged for me was a really exciting time because it meant I was well enough to go home, but my baby wasn't well enough to go home, and that was the hardest part, is walking out of the hospital without your child. Because it doesn't feel right, and it's not right, but it's a temporary situation. And I think that is the biggest thing you have to remember, is everything you're going through is temporary, and take it day by day, because you will never walk out of that hospital without your child feeling okay. I had a 2-year-old at home, I had a husband at home, and I had to somehow find a balance between all of that.
You are able to not only be there for your new baby, but you're able to be there for your family. You're able to go home and see your other children on a daily basis instead of being hundreds of miles away.
From my experience, having the NICU here where we live was immensely convenient. And not just a convenient to have something here, but to have really terrific care and great professionals and exceptional medical services.
Just kind of decompress from the NICU, because you can't spend all your time in the NICU. As much as you want to be with your child all the time, you need a break. You really do, because it's mentally exhausting, and you just had a baby. It's physically exhausting.
It is hard to have a baby in the NICU, and especially with another child at home where you have to leave your baby and go home to your other kids. But I left every night knowing that my baby was in good hands, and knowing that he was being cared for, and that if he was crying, a nurse would be happy to pick him up and love him and put him back down and get him to sleep. Every day we knew exactly how much he weighed and how he ate in the night, and they filled us in the little parts when we were gone. So you never feel like you don't know what's going on with your baby.
We allow you to come in 24 hours a day. You can hear exactly what's going on with your babies when the nurses are changing over, when the physicians are changing over.
We allow visitors in the NICU, but our space is small, so we want to make sure that your baby has the right visitors at the right time. Certainly we want your baby to be held and to be cuddled by the people that you want your baby to be held and cuddled by. So when you're admitted, we will ask you to fill out a visitation contract with us. Take some time and really think about who are the people that you want to visit your baby in the NICU. Once those 4 visitors are selected, we will file your form in your chart, and when somebody comes to the NICU and wants to visit your baby, we will be asking them for some form of identification. When they first enter the unit, they come through our front doors, and they will encounter a locked door. And that's not because we don't want them to be there, it's not because we don't want them to participate. We just want to be sure that the people who are within our unit are the appropriate people to have there. So just pick up the phone, identify yourself, let us know who your baby is, and we'll be happy to buzz you right in. We will ask them to wash their hands very thoroughly before they come in, and we'll also ask them to wear a yellow gown when they come in. Again, that just cuts down on some of the infection control, the germs that come in and out of the NICU.
So many times when a baby is admitted to the NICU, they are started on IV feedings or TPN, total parenteral nutrition. And this is because a lot of times they may have issues that the doctor needs to work with first, like maybe their GI tract is not fully developed yet.
Typically we transition slowly from that TPN over to what's called trophic feeds. and that is stimulating the GI tract, and it's basically considered just small feeds just to get the GI tract ready to start working. Once we get that full volume feed through the tube, we transition them over to either the nipple or the breastfeeding. Oftentimes we do both.
There's usually a need to fortify it with a human milk fortifier that provides the baby with the extra calcium, phosphorus, protein that they need. What we're trying to do is mimic the type of nutrients that the baby would get if they were still in utero.
Between 34 weeks and 40 weeks, a baby's head or brain size doubles. It's half at 34 weeks, which parents are completely unaware of most of the time. So it isn't just weighing babies weekly that's important, it's taking a measurement of their length and a measurement of their head circumference.
The reason that we measure the length is to make sure that their bones are developing and growing the way that they should. And the reason that we measure the head circumference is to look at that brain development and that neurological development and make sure that their brains are growing appropriately. One way that we know if we're not feeding them adequately is if that growth isn't appropriate, and we can increase the feeds based on that.
So when your baby's ready to go home, we will work with the physician to determine if the baby needs some supplemental feeds in addition to breastfeeding that will help them continue to grow.
We used to think that these preemie babies, because they were small, as a group tended to be smaller, and we were seeing statistics that proved that. Unfortunately, we weren't paying attention to the fact that if we looked at the nutrition and continued with the nutrition that we started while the baby was still in the NICU, continued with the extra protein, continued with the extra calcium till a year of age, most of these babies catch up, not within 2 years, but within a year.
In the NICU, we're looking at basically 3 phases of the swallow. The oral stage, which is pretty obvious when you're looking at use of the pacifier, improving their ability to coordinate the sucking and swallowing and breathing when it comes to either breastfeeding or using the bottle. And we also look at the pharyngeal stage of the swallow, which is managing the flow and the rate coming from the bottle or the breast, and making sure that the baby is not actually aspirating or having some of that go down the wrong way into the lungs. And we do look at the esophageal phase as well, which looks at reflux.
We have discovered that breast milk does many, many more things than we ever imagined. And one of the first and most important things is the fact that breast milk, the colostrum in particular, helps the immune system for babies to mature. It's so important that even very, very sick premature babies still on ventilators are given small amounts of the colostrum, perhaps every 6 hours, so that the immune system can mature.
Having a baby early is a very stressful time for a new mom. So if a mom has a baby prematurely, lactation services will step in and try and help a mom with her milk production.
We know that breast milk is the best food for our preterm babies for sure, but even those sicker populations of term infants as well. So we'll get the mom started with pumping so that she can, maintain her lactation while her baby is not able to feed. For information for them as to what pump's going to be the best one for them, we'll help them to, get either a rental or a loaner type pump so that they can use that if they don't have access to their own.
Breast milk will jumpstart the immune system for babies. It's so important for that premature baby to have breast milk because we know that it helps with brain development. Babies who have breast milk have much less likely possibility of getting what we call NEC or necrotizing enterocolitis, which is an infection of the gut, and babies can die from that. And so we know that giving a premature baby, breast milk is absolutely the best. We truly believe that any child who is breastfed, whether they're a normal newborn or whether they're a premature newborn, will be healthier and of course smarter.
Being able to do skin to skin is one of the best things you can do for yourself and for your baby. it just feels incredible to be able to have your baby on your chest and just, I mean, you feel like you're in sync with them, and it's the closest you can feel to your baby in that situation.
In the NICU, we try very hard to encourage skin-to-skin contact. We have robes available so that you can nestle with your baby skin-to-skin and still be covered. If you put even a little tiny preemie skin-to-skin with mom, they will stay warm enough just from mom's heat. You can even put twins skin-to-skin with mom, one on each breast, and they change temperatures independently. They can change temperatures over 100 times in an hour. It helps the baby's oxygen levels. It makes their breathing more relaxed, much accelerated brain development. Pain control for the babies. It decreases their risk of infection. Skin-to-skin will also decrease the length of stay, slow their heart rate down and stabilize their vital signs. They will relax their muscle tone. If you put that baby skin-to-skin with mom, almost all of that time is a quiet sleep that enhances growth. They actually measure the stress hormones, and those stress hormones are about half of what the baby would be if they were just lying in a crib or on a table. Increases the amount of safety the baby feels. Safer, more confident, more peaceful. So it affects them not just in their baby stage, but it affects them as they grow throughout life.
To me, the nurses were amazing. I would see the nurses outside of the NICU and they would ask how my daughter was doing. They would call when they weren't even on shift to help pass along a message. And that's extraordinary. I mean, they're really not just there to, clock their shift. They're there because they care and they're passionate about what they do.
I got to hold him for the first time, and that was just a wonderful experience. And I had a couple nurses actually on each side of me holding my shoulders and just comforting me. And I'll never forget that. Actually, it was just a wonderful experience to be able to hold my baby for the first time and get to touch him and smell him and love him.
Watching Leah graduate from getting her IV taken out, getting off respiratory, and it all happened within, maybe 2 weeks, and it was just, everything was snowballing, and it felt so good to be losing all of those machines and monitors, and it was an incredible feeling. And so we really felt like, this is it, we're gonna be home in a couple weeks. And then you get to that feeder and grower stage, and everyone tells you that it'll take a while, but you don't believe it because you know how fast everything has been going. But it takes a while.
We're trying to always stay as good as we can be and strive to be better, but that's dependent upon the input from our parents. And we ask them to let us know about things that they like. If they like having their baby, held in a certain manner or jostled in a certain manner, tell the nurse that, because we'll have all the nurses do that.
We are incredibly lucky for a relatively small community to have a hospital who has such an advanced NICU, and they really do strive to be better every single day.
Our bottom line is the safety and welfare of every baby there. Each one is considered to be as important to us as one of our own children, or for someone like me, a grandchild.
When you finally hear those words that you are on your way to be discharged, it's a very, I had a huge mixed emotions. I was very excited, but I had grown so attached to the nurses and the doctors and lactation and nutrition and speech therapy, all of the people who were helping my daughter grow and get healthier every single day. I was afraid to leave them. The whole team makes sure that even though they think you're ready to go home, that you and your family are ready to be able to take your baby home. And I think that was really important to me, because there were days where I was like, I can't do this at home. And I didn't have the confidence, but they teach you everything they feel like you need to know at home. The point is to have a healthy baby and to bring that home and to be as worry-free as you can be. You're always going to worry about your baby, and that's not going to change.
Because premature babies are immature when they're born, their brains are also immature. So after the baby goes home, we want to be sure that they are meeting their developmental milestones like other babies their adjusted age would be. Meaning if your baby is born 8 weeks early, then we would score your baby developmentally on a baby that would be 2 months younger than your baby is currently. We want to be sure that your baby's meeting those milestones. So at the follow-up clinic, we meet with a speech therapist, physical therapist, developmental specialist from the Child Developmental Center, and a dietitian and a nurse to be sure that your baby is developing the way he or she should be. If there are some lags in development, then we can recommend some therapies that can get your baby up to or even exceeding the development of babies that are that age.
When we've gone back into looking at all of our data, the survival rate of all of our babies at KRMC is extremely good.
Our experience has been babies leave here healthy, parents are happy, and they grow up to be just like any other child as a toddler, school age, and beyond.
There's no scientific reason why he should be here today. I've had several doctors tell me it's a miracle that he's alive today. And so I know he's destined for greatness in some way. So maybe all of his climbing will lead him to become an Olympian in some sort. Or I'm not sure what he'll do with life, but I know that both of my kids are going to be something special when they grow up. They've had such an amazing beginning.
Now he is a very busy 2.5-year-old boy. Running, jumping, playing, using the word no a lot, pushing his dogs around, playing with trucks, being very, very boyish and healthy, happy, and gets to come back and say hello and thank you to all the NICU staff that helped him get through that.
Leah now is 4 months old, and she is more than we'd ever hoped for. She smiles all the time, she talks, she's perfect, and she's everything we hoped for. She was worth everything we went through, and all the low days. They don't even matter anymore because she's happy and she's healthy and she's home with us.